We are joined now by Dr. Holly Puritz to discuss financial models for the future. Dr. Puritz, it's great to see you.
Thank you. I'm glad to be here.
So a lot of different financial models are going to be discussed at ACOG this year. Now you specifically are going to talk about bundled payments. Talk to me a little bit about what that means.
Sure. So healthcare is moving from fee-for-service to value-based payments. And what that means is that there's a lot of inefficiencies in the system, and by bundling payments, there is a way to improve the inefficiencies and decrease the variation, which will ultimately lower costs of care.
And it also helps the patient too, I assume.
It does. For the patient, we want to make sure the quality is always there, but patients are now more and more responsible for the cost of their care with high deductible programs. And so if there are ways for a patient to get the same quality care, but because the cost is transparent and they can shop for lower cost, that's a positive thing as well for the patient.
Absolutely. So talk to me about how these payments are operationalized.
So bundled payments basically say that one provider or one entity is going to be responsible for the entire care of that patient. Think about maternity care.
Okay.
It's 9 months and then the infant is delivered and it's about a month of postpartum care. And instead of just being responsible for your silo, you're responsible for all of it. So all of a sudden you have to have an interest in which hospital do I deliver at? Which nursery do I use? If there's 2 medications, do I pick the one that's lower cost but equally good? And you all of a sudden have basically some skin in the game, and physicians have never known or been interested in cost, but it's really very important.
Now, is this something that the physicians are discussing amongst themselves, or are they bringing the patient into the dialogue as well?
So the physicians are not really discussing this among themselves. I wish that was the case. Basically, CMS is starting to mandate that this is the way care is, and so hopefully some forward-thinking physicians and hospitals are starting to get on the bandwagon with bundled-based payments and deliver better care and better cost.
Talk to me a little bit about some kinds of these payments that OBGYNs might encounter in their practices.
The most common one is maternity care. There's been a couple of bundled payment programs in the country with maternity care. And it basically, like I said, looks to say you're going to be responsible. You start when the diagnosis, when the patient is delivered, and it's retrospective. You look back over those 40 weeks, and some of the bundled care includes neonatal care or nursery care, some doesn't. And it involves the physician in learning about clinical variation. If a hospital, for example, has to, or for surgery, has to order 12 different types of sutures because every physician has a favorite, versus there's one suture that's equally good and half the cost, and the hospital can order it in a large volume, which makes more sense from a business sense.
Right.
But physicians have never had to think about that. If there's savings in a lot of these bundled payments, the physicians are able to participate with some of the savings, and so therefore they have a little more incentive to start to look at clinical variation.
Makes sense. All right, so looking back, do you have lessons that you've learned from bundled payment contracts?
Sure. So with the work that we've done with the Accountable Care Organization that I'm a part of, we have had some bundled payments. And there's, I think, probably 3 or 4 really important lessons. The first would be that it's a team sport. Everyone on the clinical side and on the administrative side has to be equally involved, because there's so many small points for savings which ultimately add up. The second thing is you need timely data. If you don't know that you're costing more money or less money, you can't fix it in real time while you're taking care of that patient. So finding out just from claims data 18 months later that it was expensive gives you no opportunity to correct it. The third thing is that you have to have a large enough number of patients. There's always statistical aberrations with small numbers, and if you don't have a large group of patients, you can get hurt even though you're doing good care. One patient can really bend the curve. And you have to have physicians committed to decreasing clinical variation. It can't be my way or the highway. It has to be, there's some good evidence that this is best practice, and we're all committed to doing it.
All right, Dr. Holly Puritz, thank you so much.
My pleasure. Thanks for having me.
ACOG TV has all the coverage you want with the big events and key newsmakers. Be sure to check out our content, which is updated each day here on YouTube from the ACOG 2019 meeting here in Nashville.